Hello everyone and welcome. I'm Professor Shebu Oricha-Bello, and in this lecture we're going to work through the cephalosporins, one of the most widely used families of antibiotics in all of clinical medicine. Over the next few slides I'll take you from the basic base chemistry right through to how we actually choose these drugs at the bedside. Whether you're a medical or a pharmacy student, my goal is simple. By the end of this video, you should be able to look at a drug name, recognize it as a cephalosporin, place it in the correct generation, and know what it treats. So grab a pen, keep this tab open, and let's get started. So what exactly are cephalosporins? At their core, they are semi-synthetic derivatives of cephalosporin C, a compound originally isolated from a mold called acremonium, which you may see under its older name, cephalosporium. It was discovered by Giuseppe Brozzo off the coast of Sardinia back in 1945. Like the penicillins, they belong to beta-lactam family, and they are bactericidal, meaning they don't just stop bacteria from growing, they actively kill them. There are 5 generations grouped by their spectrum of activity, and as we climb the generations, each one tends to gain gram-negative reach and more stability against beta-lactamase enzymes. And here's a naming clue to hold on to right from the start. Almost every cephalosporin name begins with Ceph, or Kif. Spot that and you already know the class. Now let's look at how these drugs actually kill bacteria, because the mechanism explains almost everything else we'll discuss today. It's a 4-step cascade. First, the drug diffuses through the cell wall and covalently binds the penicillin binding proteins. These are the transpeptidase enzymes that build the wall. Second, by binding them, it blocks the cross-linking reaction that stitches the peptidoglycan strands together. Third, without that, cross-linking, the wall becomes weak and unstable. And fourth, the bacterium's own autolytic enzymes finish the job, causing osmotic rupture and cell death. Here's the key insight I want you to remember. The beta-lactam ring works because it mimics the alanine terminus that the enzyme normally grabs. That's why these drugs only kill bacteria that are actively growing and dividing, and it's why we call them bactericidal. Time out for a little chemistry. Don't worry, just enough to make the rest make sense. The cephalosporin core is called the cephim nucleus, and it's a beta-lactam ring fused to a 6-membered dihydrothioazine ring. That fused structure is actually more resistant to many beta-lactamases than the penicillins are. 2 side chains do most of the work. The R1 side chain at position 7 governs antibacterial activity and spectrum, and importantly, it's also what drives allergy cross-reactivity between agents. The R3 side chain at position 3 tweaks the pharmacokinetics, things like half-life, absorption, and metabolism. So whenever you see 2 cephalosporins behaving quite differently, it usually comes down to these 2 side chains hanging off that same shared cephim core. Here is the big picture that ties this whole lecture together, so pay close attention to this slide. As you climb the 5 generations, there's a very predictable shift in coverage. The first generation is dominant against gram-positive organisms, your staph and your strep. As you move into second and third generation, gram-negative coverage expands steadily, but gram-positive coverage narrows. Then something interesting happens. The fourth generation swings back to give you true broad-spectrum coverage, strong on both sides, and the fifth generation even recovers activity against resistant gram-positives like MRSA. Two drugs to flag here, ceftazidime and cefepime. Both reach Pseudomonas. If you remember nothing else from this slide, remember the seesaw, gram-positive strong at the bottom and gram-negative reach at the top, and balance restored at the very top. Let's now take the generations one at a time, starting with the first. First generation cephalosporins give you excellent gram-positive cover. Staphylococci and streptococci with only modest gram-negative activity against organisms like Proteus, E. coli and Klebsiella. Importantly, they do not cover MRSA or Pseudomonas. The drugs to know are cefazolin, given intravenously, and the oral agents cephalexin and cefadroxil. Clinically, these are your workhorses for uncomplicated skin and soft tissue infections, for simple use, and this is a big one for exams, for surgical prophylaxis, where cefazolin is first line. And here's your memory hook. The first gen names carry the FA or PH sound. Cephalexin, cefazolin, cefadroxil. Moving up now to the second generation. These retain reasonable gram-positive activity, but they add more gram-negative coverage. Organisms like Haemophilus influenzae and Neisseria. A special subgroup, the cefamycins, cefoxitin and cefotetan, also add anaerobic cover, including Bacteroides fragilis. You'll sometimes see the coverage summarized with the shorthand HMPK. The key drugs are cefuroxime, cefaclor, cefprozil, and those two cefamycins. Clinically, they're used for respiratory tract infections, sinusitis, and otitis media, while cefoxitin and cefotetan are useful for intra-abdominal and pelvic infections and for colorectal surgical prophylaxis. Your mnemonic here is FOX and FUR, cefoxitin plus cefuroxime. And remember, the anaerobe drugs are cefotetan and cefodrotin. The third generation is where gram-negative coverage really opens up. You get broad gram-negative reach, though with somewhat reduced gram-positive activity compared with the first generation. Ceftazidime is the standout because it adds Pseudomonas aeruginosa, and critically, several of these drugs penetrate the cerebrospinal fluid, so we use them to treat meningitis. The key drugs are ceftriaxone and cefotaxime, ceftazidime for Pseudomonas, and the oral agents cefixime and cefdinir. Clinically, this generation is enormous. Meningitis, community-acquired pneumonia, sepsis, and ceftriaxone in particular is the go-to for gonorrhea, for Lyme disease, and as an empiric workhorse in the emergency department. The naming clue is in the suffix oimi or imimi to ceftriaxone, ceftazidime. Now the fourth generation, which I described earlier as the swing back to true broad spectrum. These drugs are strong against both gram-positive and gram-negative organisms. They cover Pseudomonas aeruginosa, and they're stable against many beta-lactamases, including AMPC enzymes. Plus, they get into the CSF well. The key drug you must know is cefepime, given 4 or IM, cephalosporin is the other. Clinically, cefepime really shines in hospital-acquired and ventilator-associated pneumonia, as empiric monotherapy in febrile neutropenia, and for serious gram-negative and mixed infections. And the mnemonic is short and sweet. The 4th generation hides a PI cefepime, cefpiron. And now the 5th generation, the newest and most advanced of the group. What sets these apart is that on top of broad spectrum activity, they cover MRSA and resistant pneumococcus, and they manage that by binding an altered target called PBP2A. They have good activity across both gram-positives and gram-negatives, but one caveat: ceftaroline lacks reliable Pseudomonas cover, so don't reach for it there. The 2 drugs are ceftaroline and ceftobiprole. Clinically, they're used for MRSA skin and soft tissue infections, for community-acquired bacterial pneumonia, and for complicated infections that need MRSA coverage. Your mnemonic, the 5th generation rolls with RO, ceftaroline, ceftobiprole. Let's pause here and pull all of those memory aids together, because this single slide is your exam survival kit. Run down the generations by name pattern. 1st gen is the FA or PH sound. 2nd gen is FOX and FUR plus the anaerobes. 3rd gen is the ONNI or IME suffix. 4th gen is PI. And 5th gen is RO. Then layer on the route rules. Here's a neat oral clue. Names containing OR tend to be oral: cefaclor, ceftiturin, lorocarbif. And nearly all 4th and 5th generation agents are 4 or IM only. Finally, the seesaw rule ties everything together. Gram-positive is strong at generation 1, tips over to gram-negative by generation 3, and levels out at 4 and 5. Honestly, screenshot this slide, you'll be coming back to it. Let's talk pharmacokinetics, the ADME story. For absorption, both oral and parenteral agents exist, though most later generation drugs are 4 or IM only, and food can delay some of the oral formulations. For distribution, cephalosporins penetrate most tissues and body fluids very well. The ones that reach the CSF are ceftriaxone, cefotaxime, ceftazidime, and cefepime. Well, worth memorizing, but they get poorly into intracellular and vitreous compartments. For excretion, most are cleared renally, so you must dose adjust in renal impairment. The important exception is ceftriaxone, which is largely eliminated in the bile and needs no renal adjustment. And one more crucial concept: true cephalosporins show time-dependent killing. Their efficacy tracks how long the free drug stays above the MIC, the percent T above MIC, which is exactly why frequent dosing or prolonged and even continuous infusions can optimize outcomes. Now let's put everything together clinically, matching each generation to its go-to role. 1st generation, think cefazolin and cephalexin for skin and soft tissue infections and for surgical prophylaxis. 2nd generation, cefuroxime and cefoxitin for respiratory infections and intra-abdominal and pelvic cover. 3rd generation, ceftriaxone and ceftazidime for meningitis, community-acquired pneumonia, sepsis, and gonorrhea, with ceftazidime specifically for Pseudomonas. 4th generation, cefepime for nosocomial pneumonia, febrile neutropenia, and serious gram-negative infections. And 5th generation cephalosporin for MRSA skin infections and community-acquired pneumonia. The rule of thumb to carry with you: climb a generation when you need to hit tougher gram-negatives and drop back down for reliable gram-positive coverage and simple infections. No antibiotic lectures is complete without asking the hard question: why do these drugs fail? There are 4 main mechanisms of resistance. First and most important, beta-lactamases, enzymes that hydrolyze the beta-lactam ring, and their extended spectrum cousins, the ESBLs, which can inactivate even the later generations. Second, altered penicillin binding proteins such as PBP2A in MRSA, which lower the drug's affinity, and remember, that's exactly what our 5th generation agents were designed to overcome. Third, porin loss. Gram-negative bacteria down-regulate the outer membrane channels the drug needs to get in. And fourth, efflux pumps that actively pump the antibiotic back out before it ever reaches its target. Our countermeasure: cephalosporins with beta-lactamase inhibitors. Combinations like ceftolozane, tazobactam, and ceftazidime, avibactam can restore activity against many resistant organisms. Let's cover safety now, because you'll be asked about this constantly on the wards and in exams. Overall, cephalosporins are generally well tolerated. The most common issues are GI upset and diarrhea and rash. Hypersensitivity reactions range from mild rash to rarely anaphylaxis. A couple of specific ones to know: the drugs with an MTT side chain, cefotetan and cefoperazone, can cause a disulfiram-like reaction with alcohol, and they can lead to hypoprothrombemia and bleeding. And as with any broad-spectrum antibiotic, watch out for C. difficile colitis. Now, the question everyone asks: what about penicillin allergy? The cross-reactivity is driven by R, one side chain similarity, not by the shared beta-lactam core. The true cross-reaction risk is actually under 1%. Those older 5 to 10% estimates were overstated. Risk is highest when the side chains match, for example, cephalexin and ampicillin, but cephalosporins with the similar side chains are generally safe alternatives. Let's wrap up with the 5 big ideas I want you to walk away with. 1. Cephalosporins are bactericidal beta-lactams. They bind penicillin binding proteins and block cell wall cross-linking, much like penicillins, but they're often more beta-lactamase stable. 2. Generations equal spectrum. Gram-positive strength gives way to gram-negative reach. The 4th generation is truly broad, and the 5th adds MRSA. 3. Learn the name patterns. F8, then OX and UF, then OME-TN and IME, then PI, then AO, and you can map almost any drug to its generation. 4. Match the drug to the infection. Cefazolin for skin and prophylaxis, ceftriaxone for meningitis, cefepime for serious gram-negatives. And 5. Allergy risk is low. Cross-reactivity depends on the R1 side chains, not the core, and the true risk is under 1%. That's the cephalosporins. If this lecture helped you, please give it a like and subscribe, and I'll see you in the next one. Thanks for watching.